we'll go ahead and get started. I know some folks are still coming in, and I want to thank you for joining us here this evening at Castleton United Methodist Church. My name's Laura Wilson, and I have the great pleasure of serving as your moderator this evening for our third out of 4 panels focused on homelessness and housing insecurity. And if you've had the opportunity either to be here in person, and I recognize some familiar faces, so I know some of you have, or if you've caught these online, and we do post these to our website at castletonumc.org after each session. If you've had the opportunity to see any of these, you know that we focused on a different subtopic each time. And what we've done, I'm using the royal we here, I haven't actually done any of this part, but recruited fantastic experts in each of the subtopic fields to share with us their expertise, their experiences, their understanding on these specific issues. And today we're going to be talking about health and how housing influences health outcomes, and how we have this relationship in terms of health and housing, homelessness, housing insecurity, and I think just writ large also in SES, or a socioeconomic challenge, right? But there's a relationship there. So I do want to remind you before we get started of a couple events that we're doing here through the church, and to let you know that this summer Castleton has partnered again, we did this last year as well, with Gleaners, and we are doing their food summer distribution program at the shopping center parking lot just north up this way at 75th and Shadeland every Tuesday. So we missed it for today, but from 3 to 5 next Tuesday, you can mark your calendars, all the way through August, we'll be serving food. You can sign up, and you can do that at castletonumc.org/Gleaners. But I'll also say, I've heard people say you can also just show up and help volunteer. And I know sometimes I'm more of a show up than sign up kind of gal. The most important thing is you're there, right, and able to participate. So I encourage you, if you feel so called, to help out on those. And I also want to tell you, I mentioned you can watch these forums online. If you missed the first 2, or if you want to rewatch this one, or if you're unable to make it to our August 6th, you can go to castletonumc.org/housing. Our final installment of this series will be August 6th at 6:30. I like to say same time, same place. The date, of course, is different, and we'll be focusing on the government's role in housing on that date. The last thing is that we're continuing to take an offering for the Lawrence School Emergency Fund, and that directly helps support the students and their families facing a housing or food emergency. If you caught our very first panel, we focused on housing and education, and we learned from our experts in that panel how challenging it is for young people in our community who have housing insecurity, who might be homeless, and are still trying to pursue their education, who are seeking to improve themselves, right? And that's part of what this emergency fund for the Lawrence School can help contribute to help make that difference. So we have plates in the back if you feel, again, called to participate in that. Now, I want to tell you, my name's Laura Wilson. Professionally, I am a political science professor. As I've told our panelists, I know very little about health, even my own, quite frankly. So as I ask these questions, I'll be including questions that you, our audience, submitted beforehand. And you can do that again on our website, castletonumc.org/housing. We'll also be asking questions with regards to these topics most broadly, but it's my pleasure to get to serve as the moderator because I hope we're able to have a great discussion and a better understanding of this relationship in terms of how housing impacts health and outcomes. And it's something I genuinely ask as questions because these are things that I don't know. But luckily for you, we, and in this case, Miss Linda Bailey, has organized a great panel of experts that will be able to address those. So I want to go ahead and invite our panel of experts to introduce themselves. And I want to pre-warn them. I know there's always that sense of humility. You don't want to oversell yourself. You don't want to talk about too much. But in fact, I'm going to ask you to give us a biography of sorts to explain how you come to this panel, why you're on this stage, what your expertise is, what your background is, and just to give our audience a sense of truly the breadth that we have represented on stage here this evening for you. So.
All right, well, Good evening. Is this working? Hi, my name is Chaudhary. I am professionally the director of the Indiana Division of Mental Health and Addiction at the state of Indiana, so with the Family and Social Services Administration. It's a lot of acronyms. I'm also a lawyer by background. I call myself a recovering lawyer because I don't practice anymore, and I don't ever plan on practicing again. But it's relevant to this because for 10 years I was at Indiana Legal Services, which is a civil legal aid organization, and so I, would go to eviction court and deal with some other housing matters quite a bit, and obviously got to know the kind of ins and outs of over 1,000 clients, and oftentimes I think housing stability was kind of one of the through lines, right, that follows folks through through various stages of poverty. So I could bore you with like what DMHA does sort of regulatorily, and we could probably talk for hours about it, but we don't want to do that because it's a long day. So I'll say our job, and this is kind of important, and we'll get to kind of a counter to this in a little bit, but our job, if you were to boil it down to a couple sentences, is to increase the capacity for treatment of mental health and SUD services in the state. And I use that word capacity very intentionally because the flip side of capacity is demand for mental health services, right? And any of you that have experienced, trying to navigate, and this is healthcare writ large, it's not just mental health, but it's especially prominent in mental health sometimes. If you've experienced the challenges of trying to get into mental health care or mental health services, and you've wondered why it's sometimes so difficult, the main reason is that there is a significant and growing gulf between the capacity of the system and demand for the services. And what happens when that exists is that providers have to draw lines, right? They have to, serve certain people or certain diagnoses or take certain types of insurance. And because if they don't do that, if they just everybody throws their doors wide open, says just come on in, and there's not enough capacity, what happens? Like they go out of business or they just are instantly full. And so a lot of times the frustration, on its surface would be because of that lack of capacity. But it's really important to think about what's driving that increased demand as well. Because if we never close that gap, we're never going to get to where we need to be. So that's, I think, the why of why I'm here today is to, even though our day job, right, is to increase capacity, it's really, really important for us to address the demand side as well. My fellow executive branch employee.
Good evening. Oh, that's only 4 people. Good evening.
Good evening.
Greetings and salutations. My name is Antoinette Holt. I am the current director for the Office of Minority Health. I'm here because Linda Bailey told me to be here. And so when Linda Bailey calls, you answer. How my lovely history in regards to where I'm at, the Office of Minority Health's primary objective is to address the needs and concerns of racial ethnic minorities throughout the state, eliminating health disparities, creating equitable solutions, and that's the 10,000-foot pole of it. We do a lot in regards to addressing the needs and concerns of our underserved, underrepresented, and marginalized communities. My big, long biography. I've been everything in the state. I've been an intern, I've been an epidemiologist, I've been a deputy director, I'm a division director, I've sat on executive staff, and we do more beyond the state. We have the opportunity to serve on a regional and a national level where we're seen as an expert in regards to health disparity, equity, and different things like that. What drives me is because I have a servant's heart, so I've always been a proponent for the people that are underrepresented. And so this is the opportunity for me to be able to give back and to do what I can do for those that are in need. I believe in educating and empowering people, allowing them to be able to make informative decisions and choices that's going to allow them to have better health outcomes, because I want you to live your best life, right? And so that is essentially what I get to do. I get to partner with wonderful people like Linda Bailey and Dr. Turman and my other friend to my right, and different things like that, and what we get to do, which is an awesome opportunity. I get to be at some tables that people aren't always at, and so I make sure that they are at the table and not just an afterthought, and that they're part of the process in regards to what needs to be done in different communities and things. And so that's just a little part of what we get to do. Now, in perspective, personally, I've been at all levels. I've been where I've been uninsured. I've been where I've slept on the couch. I've been different things in my life that has brought me to this opportunity. So am I empathetic a little bit in regards to some people that experience some trials and tribulations? Of course so. That makes me even more determined in the efforts of what we do to make sure that people have equitable opportunities to be able to, again, live their best life. And so that's a reason why I get to be up here and get to join and have a good evening with you, because I know you're going to ask wonderful questions. I just feel it in my bones that you're going to interact with us and different things like that. But that's what we hope. And then I get to hang out with Dr. Turman, so I'm going to have a great time. So thank you for the opportunity.
Hello. Oh, there we go. Hi, everyone. My name is Jack Turman, Jr. I am a professor of pediatrics at the IU School of Medicine here in Indianapolis. 6 years ago this month, I started what is called the Grassroots Maternal and Child Health Initiative for the state of Indiana. This initiative is born out of many years of experience that I've been blessed to work with really amazing women from marginalized communities across the United States and around the world, and learning from them and about how to change the inequitable systems that we know lie at the heart of poor maternal and child health outcomes. The initiative, the Grassroots MCH initiative, started by me going around the state and training and mentoring women from marginalized communities that have lived experiences of poor maternal and child health outcomes to become what they're now well known as Grassroots Maternal and Child Health Leaders. They're community activists, developers, community change agents. And when I got my grant that supported this effort, I remember telling the funders, they were like, what are you going to do? What are you going to focus on? What is going to happen? I'm like, I don't know. Because, it depends on the women. I don't know the problems of marginalized communities. I'm not from there. I'm not from Indiana. I'm not a woman. So we have to go and trust that, we're going to, my hashtag, if you follow me, is hashtag Ask the Women, because if you want to know how to improve maternal and child health in Indiana, ask the women. So the interesting thing was that, and what brought me here tonight and what consumes so much of my time now is that if you go around Indiana and you ask women from poor communities, what's the biggest barrier to your maternal and child health? It is the lack of, and they use these adjectives, safe, the lack of access to safe, affordable, quality housing. Number one across the state. That is what women tell us. So the women were like, so Dr. Jack, we gotta do something about housing. And I'm like, oh my gosh, housing. And so, away we start on the journey. And so 2 years ago, I was really blessed that I received funding from HRSA, which is out of the U.S. Department of Health and Human Services. I received a large, what's called Catalyst grant to do something innovative to improve birth and infant outcomes. And so, in our proposal, which we'll talk about tonight, I'm sure, we built an intervention, or we're implementing an intervention here called Healthy Beginnings at Home. We're only the second state of the union to do this. The first is Ohio. And we're in full force, and I'm sure I'll get asked about it, so I'll keep you in suspense about that. So, and the second thing is that is very different from what Ohio is doing is that the women across Indiana taught me you can't just give people housing. You have to change the inequitable legal and judicial systems that drive people into housing insecurity. So I recruited my awesome lawyer partner, Adam Mueller, who heads the Indiana Justice Project. So he heads our health justice intervention, which I think I'm gonna get questions about. I'll keep you in suspense about that. So, so we're implementing these 2 interventions here. We're celebrating our 2 years anniversary next month of this. And so I'll keep you in suspense and I'll fill you in a little bit about that. So that's what brings me here. So.
Excellent. I like suspense. Since we talked just broadly why we're here, I always like to start with a retrospective, and in part because it's 2024, so it's 4 years since COVID. But to that point, in your respective areas, would you say the relationship, the impact of housing on health, and it doesn't have to be 4 years, in the last 4 or 10 or 20 or so many decades, how has that changed? Has that improved? Has it gotten worse? It most likely has fluctuated a little bit, but could you just describe in terms of time-wise, what have we seen, maybe with growth, regression, whatever it might be, in those fields?
Sure, I'll start. Yeah, that's a really great question. There is a very long history in health that of the relationship between poor indoor and outdoor environmental factors and health outcomes, especially on children. I'm sure you know this, right? I mean, it's been long known of the great tragedy of lead exposure on children. So this has been known and studied and talked about for quite a long time. What has changed in the dialogue probably 6 years ago, and we have to tip our hat to Matthew Desmond because he published the award-winning book Evicted. And this really had a large impact because suddenly it wasn't just housing quality, it was housing insecurity's impact on health. And so we are seeing a number of good work that is describing the impact of housing insecurity. So that's homelessness, living in a cheap motel, couch surfing, living in your car, multiple evictions, all of those things. So we're really seeing the impact on that in women and children and families. And so that's all really good, but there's very few teams doing interventions to address that, right? I mean, to address that phenomenon. And I would add one important thing about the change is that there's been a lot of focus on housing quality and insecurity on children, right? But you forget a really important player in the life of children, especially very small children, because they're not autonomous beings, right? They are dependent on being in a womb, right? And being nurtured in a womb, and then like being delivered, and then being cared for. So now we're finally beginning to see these linkages between poor housing quality and housing insecurity on pregnant people, right? And birthing people. And it's really funny because there's this like light bulb, like, oh God, we have a terrible maternal mortality crisis. Maybe like this housing insecurity and poor quality might have something to do with that. Good, we're glad we're getting there. So I would say, so please forgive me, everything I'm gonna talk about is gonna be about pregnant people, little babies, toddlers, and kids, right? Because that's my focus. So, but does that help answer? That's where I would see these important changes.
Yeah, it absolutely does. And would you say generally it has improved recently, or it's gotten worse, or stayed
Much
the same?
worse.
Much worse. Could I do a follow-up? Why?
Because you have, well, there is an incredible amount of inequity in every sphere that surrounds housing. So you have inequity in access to quality housing because of how, as housing prices go up, for instance, right? Do you know what I mean? Then it gets harder for people to get into quality housing, and the stock isn't there, the lack of building affordable housing and things like that. That's one thing. Another thing that is making it worse is, and of course, please know that there's great inequity within our state, within our country, because you really see that where you live matters. Because if you get evicted over here in Lawrence Township, you're going to have a really good experience with the fabulous Judge Bacon. And because she takes a very different approach. I'm getting ready to submit a big study where we're like documenting the inequities in Indiana around this. But if you live 20 minutes this way, you have a completely different experience. If you live in Gary, South Bend, Elkhart, Fort Wayne, in Grant County, in Evansville, it's all different. And this is truly a great problem of inequity in our state, because that to me is simply not fair. And yeah, I'll stop there. So, sorry. Amy knows me, so I'm gonna be like, okay.
Can I? Okay. So let me tell you a little bit about COVID. Okay. So what COVID did was it exposed the amplified health disparities. Health disparities existed, right? It's nothing new under the sun. It's been in existence. It just amplified it. How they amplified, the world had to stop. So you were stuck at home. So then you got to see the different things that were existing, right? So then you got to see social injustice and inequities and different things like that because you had no choice. So it had to face you. And in doing that, you had to address those needs and concerns because there's still systematic barriers. There's still racial injustice. There's still racism. There's still all these conditions and disorders. There's still disadvantages. There's still inequities. There's still all these things that exist, right? Amongst social services, systematic barriers, all these different things that exist. Now, what has afforded us an opportunity, so I would say not so much improvement, but what's veering us a little bit to the right is because of that, resources have been put into communities and different things like that that affords us to be able to address some of these inequities. Now, it's not the end-all be-all solving of the issue, right? Money is not gonna, it's like a Band-Aid over a big gaping hole. It's not gonna do it. It may help a little bit at that moment, but it's not gonna solve the things. But what it does afford opportunities to be able to address some issues and things. Now, what has to happen is, in the process of trying to create cultural humility and different things like that, you gotta get people on board, right? There's some people that understand, oh, like we were talking about before, I get the process, this is necessary for us to do right. But then you have some people that feel like, hey, we've been doing it this way all this longer time, so why we need to make any changes? And if we continue to do the same thing in the same way, I've told that was insanity, right? So we cannot continue to do things in the same process and expect different results. So that's what we have to do. We have to, I'm hurrying up, I promise you. So we have to.
Speaking facts. So.
We have, there you go. We have to make sure that we're addressing, so where I come in regards to my process is looking at how do we address this as far as from a health disparity standpoint in regards to improving the process. You know, so that's why I said in the beginning when I was talking about having people at the table, it's important to have, because you've heard if you ain't at the table, you're getting served for lunch. But what happens when people come to the table? Is there enough food for everybody at the table? Are they going to be able to take food back to the people that weren't invited at the table? You know, what is the process that's going to help these individuals and people that we're bringing to the issue? So when you have people in the beginning, if you have communities solving the community issue, you're going to be much successful in solving that, rather than bringing them in at the end of the process, expecting them to, well, hey, we done came up with this thing, and you don't bit more live on my street than the man in the moon. Now I'll shut up.
If you want, I'd listen to you for all day. Well, I'm going to stray far from my lane here, which is probably record time for me, probably. So there's this concept, and I can't say what it's called in church, maybe, but it's the guy that coined it called it encrapification, but he didn't say crap. So it's anyway. Corey Doctor was his name, and I promise this is related. I'll get to how it is. And it's just this idea that over the last sort of like 10 to 15 years, and it's accelerated during COVID, like kind of like the way fundamentally things are structured in our system and economy have just gotten worse. And the best example is the company Instant Pot, if you heard the story. So Instant Pot made this wonderful product that everybody loved. And the problem was you'd buy an Instant Pot and you'd have it for 15, 20 years. There was no way for this company to grow, right? And so they tried to come out with some stuff like Instant Pot, you know, Wi-Fi connected, you know, just like nobody wanted it because their old Instant Pot worked great. And so what happened? People know the story here. Instant Pot was bought by a private equity company who loaded it up with debt. And a couple years ago, Instant Pot filed for bankruptcy. And the problem was they were too good of a company. They made too good of a product. And that's not what our system is set up to reward, right? And how that's related to housing is because a lot of these private equity companies, they see Indianapolis, Indiana, as a sort of market inefficiency, right? Because of the reasons that Dr. Turman mentioned, because of the reasons that Antoinette mentioned. And so I don't have the exact figures, you might have them, you know, but the amount of our housing stock that is owned by out-of-state large corporate landlords and private equity-backed landlords, it's going up real high. And it's really tempting to see that as a standalone problem, but I think it's really part of this bigger problem that we can all relate to, of like this sort of, I call it the extraction economy, right? Where like instead of like creating value, people are just kind of extracting value everywhere. And obviously that's a much bigger problem than we're going to be able to solve tonight, spoiler alert. But I think it's really important to talk about all these things under the auspices of like everything is worse for everybody because of these very deliberate decisions made by a lot of people. Now, I think the one, I'll flip it a little bit because that's super depressing. I don't want to end on that. But I think the one thing I will say, you know, maybe a slight silver lining is I think that you're seeing kind of a bipartisan consensus and recognition of this particular problem. I don't think it's filtered down to housing necessarily, but you're seeing, I think, nationally and a little bit locally on the left and the right of like, you know, there's a whole sort of new conservative right that's focused on sort of family issues and sort of populism, and then there's people on the left that have been talking about this. And I think if this, and to me this is the core problem like in our society, right? Is it's not, all these things are symptoms, but the core problem is like we've allowed this extraction economy to take hold, and like housing to me is like kind of one symptom of a much bigger problem. But I don't know, I'll take my tinfoil hat off now. But
Well, I might ask you to put back on here with this question, because you talked earlier about capacity and demand. And I think relative to the other areas, we think about mental health, it feels, and this is just going to be my personal experience, so y'all can disagree, But mental health is easier to talk about now compared to, X many years. I'm a millennial and I'm a college professor, so I teach, it's now Gen Z, and they will talk just openly to me about a lot of things, so many things. But they'll talk about like, I had a therapy session and my psychologist mentioned this, or I'm having a bad mental health day. Just things that I'm 38 years old, I would have never said to my professors. Nobody else would have either, by the way. It wasn't just me. But just that little difference in change. And then I have children that are Gen Z and Gen Alpha. I think the way we talk about specific to mental health is different. So this is the conundrum, right? I feel like people are more open in discussing it. How does that relate to capacity and demand? Because it feels like that should be the solution, or that should lead to the solution, but I feel like you're going to tell me it's not.
Okay, so to be clear, like the reduction in stigma is a wonderful thing. It's not everywhere. I think there's still pockets of populations and folks that are having a little bit harder time, but the reduction of sort of stigma is a wonderful thing. We should encourage it. We should make sure that it's equitable, and that a lot of communities have the same kind of open approach to mental health that I think our can I say young people do. But the flip side of stigma reduction is what? It's increased demand for services, right? Because and that's not rocket science. Like that's just like obvious. And I mentioned earlier about we are. To be clear here, we are increasing capacity. Like we're doing all of the things that we need to do. We had all 3-branch bipartisan effort in the 2023 session. To invest a historic amount in behavioral health. I mean, we have 15 new crisis stabilization centers open in 2024. We have 13 new mobile crisis teams around the state. We were just selected for the federal government's CCBHC, which is a new treatment model demonstration project. We're doing these things and increasing capacity. But the problem is, capacity is going like this, demand's going like this, right? And part of that is reduction of stigma. But the truth is, and this is why focus on capacity is not enough. There's this concept, and I'll get kind of academic here, you might appreciate this, called Baumol's cost disease. Has anybody heard of this? And so this guy, Baumol's his name, Baumol. But and it's a little dramatic calling it disease, but the observation is that in services, or in sectors like healthcare, there is no way to use efficiencies to make costs come down, essentially. Because, you think about things like manufacturing and tech, you can offshore, you can automate, you can do things like that. But in healthcare and health and human services, there's only one way that costs go, and that's up. And so increasing capacity is inherently going to mean increasing costs. And a lot of those costs are going to be borne because of the nature of our healthcare system they're going to be fought, first of all, I think, by insurance companies, and then they're going to be, kind of, in large cases, borne by taxpayers and sort of subject to the whims of the people that appropriate funding, right? And they're going to want to know, is there an endpoint here? And the answer is no, because as capacity goes up, costs will always go up. So the only way to get those costs under control is to do what? Is to reduce demand for mental health care. And reduce demand for, and we do that by creating a mentally healthier society. That's the answer, right? So dimensions of that include things like, community connections and social fitness and all those things. But a big part of that is sort of, what's often been called social determinants, social drivers of health, and housing, I think, is the single most concrete one of those things. So in a really roundabout way, that's how housing is connected here.
Antoinette, could you talk a little bit about your role in terms of organizing the health fair in conjunction with the Indiana Black Expo and the summer celebration? What are the goals for this fair? In particular, we haven't spent a lot of time talking about race in these panels, but I think that's incredibly important in terms of the relationship with health outcomes, and it might have a relationship in terms of homelessness and housing insecurity too. I was wondering if you could address those.
Sure, in that wonderful power part question. So let me first describe as far as race. So race and ethnicity play a big driver fact in regards to a lot of disproportion that you see as far as diseases and different things. So you see people, especially people of color, 1 to 2 times more in a lot of diseases and different things and outcomes. That's because, again, access, as he was describing, social determinants of health, which in essence, if you're not familiar with social determinants of health, it's how you live, how you grow, how you listen. So your environment plays a part. Where you're at, these different things plays a part as far as how it shapes who you are, right? And so these factors intertwine with a long history of, like we had mentioned before, of discriminatory policies and different things like that, puts people at a disapproach rate. So that's why you see Black women who experience maternal health 2 times higher than their white counterpart, or that's why you see the infant mortality rate so high amongst Black babies, or that's why you may see certain conditions and chronic diseases that affect different populations at a greater rate. And so that plays a role in it. It's not just the race, but it plays a significant role as far as that. The fair that she's talking about is the Indiana Black and Minority Health Fair. It takes place during Indiana Black Expo Summer Celebration. This year was its 38th year of iteration. Thank you very much. Usually we're able to see over 14,000 people plus over a 4-day span. We try to offer this year over $4,000 worth of free healthcare screenings that people can do it. And let me say it again, it's free, 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 free. And so you have a lot of proponents of hospitals, insurance companies, different entities that play nicely in a sandbox that come and offer people the services and different things like that. So you have people that take advantage of these free services. You have some people that use this as their regular health screening per year, which we not necessarily encourage that, but we're not going to say, hey, don't come. We try to provide a primary care physician or someone who is a health professional that can help you, so nurse practitioner, or get you into a system like Shalom or communities, different things that they have where it is a fee sliding scale opportunity and different things where you can have access to that. And so it's a big conglomerate of people that come together to produce this opportunity. Again, it's not the solve it all, be all process, but it's an opportunity for people to know where they are, what they need to do. A lot of people from this have found out that, hey, I needed to do that because I was in the early stages of prostate cancer. I found out through the clinical breast exam that I had a lump in my breast, and I was able to take care of it because it afforded them an opportunity for prevention. You know, I'm old enough to where I was always told prevention's worth a pound of cure. That ain't changed. So prevention is key in a lot of things as far as what we do. So if we empower people, again, give them their numbers, knowing where they're at, different things, they can make better informed choices. And you know, word of mouth is still the greatest form of communication in the whole wide world. And so you have a lot of people that will go back and educate their loved one, different things. Because I tell people bring their enemies too to the health fair, because you know I want everybody to take advantage of this opportunity. So that's what we get to do in that diaspora of doing that. And then going from there where you create these networks of collaboration, so then you can do opportunities and programs outside of just, usually it's in July, this year is in June. So you can do these things outside of just one time a year. And so you can keep up with people, you get to their results, different things like that. So programs like the health fair or different things that Dr. Turman does, or things that are forward-facing to people, afford people that opportunity. Black barbershop initiatives, different things like that that bring stuff and resources to where people are, that's going to make them more apt to be a part of the process of their own health. At the Black barbershop initiatives, I have people, barbers come and be like, well, you know, he ain't been eating right. His blood pressure's been high and all this other stuff and different things like that. So they're running to tell me, hey, this is what's happening, which is great, right? You got people fighting because they want to be the healthiest one. So that's wonderful. But then they'll bring their families and different things like that. And then I have some traditional barbershops where no women allowed, don't come up in here. And I need to have some men there that will do educating, different things, because I don't want to encroach on your sanctuary of men process. So we want to make sure that you're still getting educated and empowered and different things like that. So what can we do to ensure that process? All that to say, hopefully answered your question.
You did, and I'm sorry, it was multi-part, but I'm a professor, so I can claim it's one question there. I like that you emphasize community too, right? Like all the different levels of community.
Can I say something about prevention? Because you talk about prevention, and in our world, prevention means something very specific. And we always hear in the behavioral health world, like, why don't you focus more on prevention? And what people mean by that oftentimes is, why don't you focus more on, like, you know, DARE type programs, like, you know, like program, like education, you know, look, that's important. Like, I mean, educating people is never a bad idea, and giving them the evidence and the science and the reasons, you know, why making good choices is good is always a good thing. We're all for that. But the truth is, you know, prevention really is stable housing. Prevention is access to childcare. Prevention is food. Prevention is those things, because, you know, there's a saying in the community. I love this saying. I didn't come up with it. I wish I did, because I'm jealous. But you know, trauma is the real gateway drug, right? And so, you know, housing instability, food insecurity, these things are adverse childhood experiences. That's trauma. That's what leads people to down that road. So if we're talking about investing in prevention, what we really mean is investing in things like we're talking about today.
You know, I don't think I realized it until we started this conversation, but just how much prevention's a privilege in a certain way. Just thinking about those times when the doctor says, well, would you like to do this? And I'll say, like, for my kids, yes, of course, I know. Or like, you go to the dentist and they're like, you want to do this treatment, it costs a little bit more, but I know. And there's the privilege of having the education, there's the privilege of trusting the system, and they're not going to do anything to me or my children. And then there's the privilege of financially being able to afford it. But if you think of it like that, it was making me think of Little Fires Everywhere. And I know it was a book, and I'm sorry, I was the person that just watched the show. But it was the show with Reese Witherspoon. My husband and I watched it a couple years ago, and there was a line that I won't forget from it where it said, you didn't make good choices. You were given. You had good choices. And I think for myself, in terms of prevention, thinking of it as a privilege in that way, whether it's individual or institutional, more systemic, right? Being given those opportunities, not just having made them, is really impactful. Jack, you teased earlier about health justice. I was hoping you would, and I think you were hoping too, right? To be able to elaborate on that a little bit more, and maybe also tell us, since it is going to be a two-part question, I know Antoinette enjoyed it, if you could talk a little bit about the housing insecurity and relationship in terms of pregnancy, infant health outcomes, how we fare in Indiana, all those things.
Yeah, great. So I'm going to start with the second part of your question to lead up to our intervention package. So first of all, here is some data for you, and I'm so sorry, I printed these out for you, and then I forgot to bring them, but I will email them to you, Laura, okay? And then and the pastor, and then it'll be available to everyone in the congregation, all right? So that, because we wrote a report on the impact of housing insecurity on maternal and child health across the maternal and child health spectrum, and some recommendations for advocacy. So I will send that to you, and then, right, is that okay?
Yes, absolutely.
All right. So here is a brief overview. What does housing insecurity do to a pregnant person? Well, we know it does a number of things. So first of all, it increases her risk of having a preterm infant. So an infant born before 37 weeks complete gestation, but 37 weeks gestation. And I want every audience to always walk away with this. The risk of a housing insecure pregnant person having a preterm infant is the same risk as her smoking. Okay? So it's the same. It's a 20% increased risk. And I challenge every audience across the country I speak to with this question. How many of you have heard of smoking cessation programs during pregnancy? Raise your hands. How many of you have heard of eliminating housing insecurity for pregnant people? It's the same risk. It's the same risk. It increases her risk of having a low birth weight infant. It increases her risk of having hemorrhaging during delivery. It increases the risk of the child spending a long time in the neonatal intensive care unit, which, by the way, is very expensive. And so that's just that, right? But let me tell you the reality of what it does to her. So she can't go to her prenatal appointments as often. And she can't afford to get multivitamins, prenatal vitamins. And she can't afford to take care of comorbid or other existing health conditions she might have, like diabetes or high blood pressure. And she often can't choose her sexual partners. It's put upon her to engage in sexual behaviors that she might not want to engage in because it might be the only way that she can have a roof over her head or that she could get food for her babies that she has. It increases her to a great chance of violence in the community. A major cause of maternal mortality in Indiana is gunshots. This is what happens when you put this person in a housing insecure situation. And don't forget, it's not just her. She's carrying a baby. And she likely, on average, has 1 or 2 other children that she's caring for at the same time. And so this is what happens when you put someone in that situation. So our intervention, and then I'm going to share, because I have permission to share with you some things we're learning about the women that we're serving here in Indianapolis. So we have 2-stepped intervention. We have Healthy Beginnings at Home. Healthy Beginnings at Home is our intervention, which is in great partnership with CareSource Medicaid. They originated the intervention in Ohio, in Columbus, Ohio. We've tweaked it some for the Indianapolis context, and we're advancing it, like working with CareSource. But so here's what you do. Here's what we do. We provide housing navigation, comprehensive case management, and 24 months of rental assistance for pregnant people over 18 years of age who are housing insecure in their first or second trimester. And so we're with them for 2 years. We're celebrating our first anniversary of our first year, of the first mom we enrolled now. And so we've built a positive social support system around every single one of these women. They each have a Healthy Beginnings at Home case manager. They have a CareSource life coach. They have a CareSource care manager. They have a housing navigator at Our Door Housing Services here. Housing navigation just means we find them places to live, and they get to help choose where they live. Guys, I think that's really important. Why don't these women have agency to select where they live? You all did. We all do. Do you know what I mean? So they want it just like we do. Do you know what I mean? So they have housing navigation services, and then they also have a housing stabilization manager at Our Door. Please know this. Homelessness and housing insecurity across our country if you don't walk away with anything from me tonight, please walk away not blaming these people, all right? Please no one wakes up and says, oh, I think I want to be housing insecure today. Do you know what I mean? Like, they have a housing stabilization manager. This is an awesome woman at our door who helps them understand like how to be a good tenant. Do you know what I mean? This concept of like what that means, how to talk to a landlord, how to work with a landlord, how to do these things, right? And then they all have access to legal services. Now you're saying, and this is going to transition into our health justice intervention. So why do they need access to legal services? 71% have evictions on their records. And in Indiana, you might have evictions on your records and not even know it. And you go to find a place, and they say, oh, we're not going to rent to you because you have evictions. They're like, what? Yeah. So 71% have evictions. 62% of those evictions are sealable. And we're doing that for all the women. So, our health justice intervention does the following. We do Know Your Rights sessions. So you might have been to some or heard about them. We go around the city. We'll do it in your church, or we'll do it anywhere you want to do it, where we teach people their housing rights and how to claim your housing rights. We do strategic litigation. So we represent cases in courts of low-income families who we believe are being unduly evicted. And we do legal policy, legal advocacy work to help work with judges and the judiciary here to help bring about policy changes to help bring equity to low-income families who are facing eviction. I have the best team in the whole world. And we've only had 2 eviction sealing clinics this year. We have our next one this Friday. We've sealed 220 evictions for families in Indianapolis this year. And we're just growing this because we've learned this is such a huge barrier to people's people being able to be housed. So in conclusion, let me tell you, we have 25 moms enrolled. We have 25 Healthy Beginnings at Home moms in Indianapolis. Right now, we're going to start enrolling the next cohort next month. We've had 16 deliver their babies. Unfortunately, one woman contacted us, and we were starting the process, and she did suffer a fetal loss. But all the others are doing well, and that woman is actually doing really well, and we built a whole support system around her. Do you know what I mean? Like around this. But these women are really amazing. A little bit about these awesome, really awesome women. 21 of the 25 are Black or brown women. 44% work. Isn't that interesting? They work. And guess what their average salary is? $16 an hour. But they can't afford a place to live. When you ask them what drove them to being evicted, here are the things. Well, the rent went up so high that they couldn't afford it anymore. And there's no affordable housing available. So they can't find a place to live. They lived in really terrible, uninhabitable conditions. And they did a cardinal mistake. They didn't pay their rent because they were living in squalor. My friends, horrible squalor I've seen across Indiana. And that gets them evicted. And that starts the cycle. There's a very strong link between uninhabitable conditions and evictions and the path to housing insecurity. They were escaping a toxic environment on behalf of their children and themselves. Violence in the neighborhood, violence across the neighbors, violence in their partner. They are, their pregnancy makes paying rent difficult. Most are high-risk pregnancies, which means, what did they go to the doctor? What does the doctor tell you? Bed rest. You can't work. You just lost your job. Now how are you going to pay the rent? And so you're evicted. And so, so these are the things that like lead them. So I say this to you all, please. Please look at them through different eyes. And take the time to understand their story. Because they didn't want to be there, right? That's not what they want. And instead of saying that woman, she didn't go to her prenatal visit, she didn't take those multivitamins, hashtag ask the woman. Why? Because I'll tell you, if she has to make a decision about doing something to feed her babies, she gonna do that. And going to healthcare sometimes can be very challenging in this situation. I'll conclude with this. What do you think the average debt of the women are? What do you think? $22,000. Where do you think most of that debt comes from? Medical. Oh, but they're all Medicaid. They all have Medicaid. So I hear this all the time. Dr. Jack, then how can they have debt? They all have Medicaid. Well, sometimes you get told you should have a procedure or your baby should have a procedure. What does a mommy do? Yes. Uh-oh, Medicaid didn't pay for that. And you get a bill. And so this, I'll conclude with this. That's the backstory. Hashtag ask the women before you start judging them for behaviors or actions or decisions that might seem uncomfortable.
I told you we would ask some of the questions you submitted, and I want to remind you before our fourth panel to please ask your questions. And you can do that by going to our website at castletonumc.org/housing. I try very earnestly to address every question that's included, or at least to address each person. They have several questions. And I want to tell you this first one, several people asked about resources. And so many community members asked us, what available resources can you recommend to them to keep them up to date with current stats and trends? And I would echo, as a non-medical professional, it's hard to find data that's both accessible to someone who doesn't understand that material, but also is up to date to say, like, okay, are things improving? What's getting worse? Like, where's a legitimate source for resources that you could recommend for us that want to learn more? And I'll just throw that out to everyone.
Everybody pointing at me. Okay, so if you have access to a computer, because I don't want to assume everybody does. If you do have access to a computer, the Department of Housing and Urban Development is a good place to where you can go. As a matter of fact, they have the annual homeless assessment report that they put out, which would be helpful if you're trying to find information and data. Also, the Department of Education puts out the annual student homelessness American report. Then there's several agencies that you can go to. Agriculture and Defense is a good place. The Census Bureau, the Office of Head Start, Health, as he had said, HRSA, which is Health Resources and Service Administration. We have so many acronyms. It's so special. So these are places that collect homelessness information. Now, Indiana-wise, you can always go to the Indiana Homeless Coalition. You can do the Indiana Housing and Community Development Authority. You can also go to in.gov. Let me just pump where I work, in.gov. You can do indy.gov. You can go to his place, which is FSSA, find out information. He would give you that website.
Yeah, I mean, fssa.in.gov.
There you go.
No, I mean, I think I would also, I mean, you may get to this, with the new public health initiative, Health First Indiana.
Yep, you can go to.
The data coming out of that and like is beautiful, the way it's laid out and the dashboards, and so I think it's still kind of being built, but it's something I think.
So you can come to the Department of Health's website. Big plug for where I really work. And then Healthy First Indiana is the program and initiative that they have where they're working with local health departments. Now, if you're the research person that just loves data, because data makes the world go around, you can also go to Google Scholar and different things and look up reports that they have as far as that exist as far as homelessness. And those are just some of the things that you can look up as far as resources to you. Now, good old-fashioned phone still works. So you can also call these lovely places and entities too.
And I would add, yeah, if you're talking more about looking for connection to resources, as in like housing resources, 211 is the best place to start, which is, it's been having 211 come over to the state right before COVID was one of those serendipitous things that I think has turned them into sort of a powerhouse of connection, and so I'd be remiss if I didn't point that out.
I would just add in here, I think they're a sponsor. I would definitely go to Prosperity Indiana. They have really good work, and the Coalition for Homelessness Intervention and Prevention has a lot of good resources. Savvy, S-A-V-I, has very good resources too. So in addition to everything that my colleagues said, yeah.
Tremendous. And I do want to say one of the things that's fantastic about these panels is a lot of times the panelists are willing to stay a little bit afterwards. So if you have a question about some of those or the work you do, which is a nice segue to my next question, we had several community members ask about opportunities to partner, right? And they said, we're involved in different organizations. We want to help address some of these health challenges. And I realize that this is very broad. Right? I'm not telling you which organizations or anything like that, but I appreciated these questions. I was saying, we hear what you're saying. We want to find a partnership. We want to find an opportunity. And so I'm wondering, in your own respective circles, are there opportunities for collaboration, or what would you recommend to someone who submitted that question as a good place to start?
Oh, okay, I loved that question, and I'm going to do, not because I'm in a Methodist church, but I'm going to do a huge shout out to the Methodists of Indiana, because they have been so incredibly supportive of all of my work since coming to IU, and I'm eternally grateful. United Methodist Women, I think it's now United with Faith, but I just love those individuals. Anyway, and so I'm not here to talk about it, but we have a whole faith-based initiative within the Grassroots MCH initiative. But here's a way you can help, because a lot of your partner Methodist churches are helping. So a huge partner in our housing work is St. Luke's Methodist on 86th. They build baby shower baskets for every single mommy in our housing program. They open up the rummage sale for free to all the women in our program, in our housing program, and in I have a whole prison program as well. They help like so much. North United Methodist Church hosts hosted our first eviction ceiling clinic. North United Methodist Church continues to partner with us on marketing and getting stuff out around our work. I just found out today another church, Episcopal Church, is going to help identify housing for women in our program and help support that. There's a lot that you, as a body of faith, can do. You can provide, and all you do is I'll give you my card. You can reach out to me, because we have mosques that partner with us, churches of different faith systems, because you think I can't do anything. Oh, you can do so much. Giving a set of towels, giving a set of sheets, giving a set of pots and pans, giving these things like that. The women are overjoyed. Remember, they're coming from housing insecurity. They have mostly nothing, right? And they get an apartment, right? And so they want to figure out how do we stock this? So so there's, in terms of it, so I think because people are called in their faith systems in different ways. Some people are called for that direct service. Do you know what I mean? Of they really want to know, they want to give a whole bunch of baby stuff to a mommy and see that joy, There's great teams at Second Pres, St. Luke's, I can't remember the other ones, I'm so sorry, that are more into the policy work we do around changing judicial practices. So they're court watching, and they're watching what happens in eviction courts and collecting data like that. So there's so many different ways that you can serve, and never underestimate the power you have to bring great joy to someone. Because it can simply be giving a basket of lotion, soaps, hand creams, stuff for a woman. Do you know what I mean? Because she never prioritizes that, right? It's always something for her babies and her kids. But giving her a little basket that has all that lotion and, that kind of stuff, do you know what I mean? Total joy. Do you know what I mean? And so there's really, for me personally, what I do in the Grassroots Initiative, there's lots of ways that you can partner and help, and we appreciate every single one. And there's and you wouldn't be alone. We have a whole lot of faith organizations across the state that do things to help the families that we serve.
Thank you. You're so kind. Okay, so in the world, as far as looking at health disparities and different things, you can partner with the local minority health coalitions that exist around the state. Specifically here, Marion County has a minority health coalition. We also, out of our office, have health equity community health workers, which have built district action plans to address health equity councils in their specific districts. So I can get you in touch with the person for that. We also have a faith-based outreach coordinator that goes around the state and different things, and would love to partner and interact with that, because you can do a lot. So let's just do that, because you've been sitting for a second. So everybody hold up the number one finger now. Hold up the number one finger. You can make a difference. It just takes one person. A lot of things that you've seen in history, it's just taking one person and different things like that. Now hold up your one finger and put down all the other fingers that's pointing back at you. We're stronger when all of it works together, right? So one person can make a difference when we all work together. What a difference we can make. So there's a lot that you can do. So don't ever say that I cannot in myself do it, because a lot of people in history would have been messed up if they just said I myself couldn't do it, right? So you can make an impact. So whether it be the physical hands-on soap towel person, whether it be the person that sits on councils or committees or different things that makes a difference in their community, whether it be the person that, because I said as a government official cannot technically talk to legislators, it can educate. but it technically can't do that. Whereas you can go and talk to your legislative body person and say, hey, this is not working, da 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 da, and you can give them that answer, whatever have you. You all make a difference, okay? And so I don't want you to think that you cannot make a difference because your input matters.
Yeah, so I want to piggyback off that, and I want to talk about activism and advocacy. So I was fortunate to quarterback the kind of Behavioral Health Commission in 2022, and then the resulting work in 2023 that led to Source and Enrolled Act 1, and I think there's some really important lessons to draw from that work. And I think they're really important because I talk to a lot of people that are interested in advocating and being activists, and quite frankly, they just don't understand how things work, right? And the barrier to entry to being an effective advocate and activist is understanding how things actually work. And so, what we were able to do during that time is we got everybody rowing in the same direction and aligned on one sort of idea, right? And, we were able to do that by aligning the different elements of change, right? The way things happen. I think number one there is narrative. We have to agree on a common story. Like for housing, I think that story is, people deserve a stable place to live, and it makes sense fiscally, it makes sense morally, it makes sense, biblically, if that's sort of where, you want to come from. So that's the story, but that's only the starting point. Right, you have to get the right people at the table. So it's not just the people in this room. This is the choir, right? By coming here, you already agree, right, that this is important. So you got to get the other people there, And so then you have to also get funding aligned. Okay, so how does the money work? Understand how it works. How do you get it aligned? You have to understand the mechanics of everything. So what's the policy and what's the programs that you're advocating for? Like, what are the policy changes? Do you want rent escrow, for example? Right? What does that mean? How does that work? How does that change things? And you have to get all of that aligned in the same direction. So I see a lot of, I think, good faith and well-intentioned infighting among sort of advocates and activists. And I think everybody's coming from a place of genuine, genuine desire to see things done better. But if you want to make things happen, you have to align. Like we had the providers and we had the state and we had the legislature, we had the judicial branch, we had the executive branch. Every single group there has different interests and incentives, but we were able to put it aside, get on the same page, and it worked, right? And that's what we have to do across the board if we don't do that. And so this is, you didn't ask how, this is more like a roadmap, but like that's the answer, right? You have to, it's going to take some folks to get aligned and on the same page in order to make things actually happen.
The mark of a good panel is that you answered questions I hadn't yet asked you, but were exactly what I wanted to know. Could we give them a round of applause, please? I think that's tremendous. And in talking about engagement and policy, we clearly see the expertise here, but I think also a lot of opportunity for us, I would say, as someone who doesn't know much about any of this particular topic, like ways that we can get involved, which is where I want to remind you that we'll have our fourth installment of this series. Our fourth panel will be on August 6th, and that's going to focus, this was actually a really nice segue, on policy, on lawmaking, on the government's role, which I think could fit into so many of the questions that we asked, not just this evening, but our previous two panels. So that'll be our final forum on August 6th. That's again a Tuesday, again at 6:30. I'm talking about the government role in housing. And I also want to remind you of two other opportunities to contribute. Again, we're partnering with the Gleaners Food Drive in terms of their food contribution to distribute food to our neighbors. And certainly when we talk about health, we have to think about food, right? And just having adequate nutrition. So if you feel called to participate, they do this every Tuesday at the shopping center parking lot at 75th and Shadeland, just up the road from 3 to 5 throughout August. And you can sign up or just show up. But sign up at castletonumc.org/gleaners. And then my final reminder in terms of taking the offering for the Lawrence schools, there were many questions people asked about children and the impact of housing insecurity and health on children. And I think we addressed a lot of those this evening, but we're taking that offering. You can go to the website at castletonumc.org/give and donate online, making a note for Lawrence Schools. We also have offering in the back, and that's a special emergency fund. So for the people in the schools that see some of these issues manifesting in the children, it gives them the opportunity to help make a difference through your contributions. Could we do one more round of applause for the panel? They were so fantastic this evening. I want to thank them for contributing their time, their expertise, and their energy. And I also want to thank all of you for being here. I hope I get to see you again on August 6th. Thank you so much, and have a good evening.